Well, thank you very much for that kind introduction and also the invitation. The topics chosen for this seminar have been really exciting. This is my second time in this top 10 conference. I was here a couple of years back as well. And what I like about this forum is that it really gives you an opportunity to think outside the box and not have any constraints and just sort of discuss a few things the way you at least see it. So we'll try to do that as well. These are my disclosures. So let me first start by the answer. So the question was optimizing heart failure treatment, and my answer is that we don't need to select drugs. We don't need to sequence them, and we don't need any substitutions. So I will try to prove my point in that respect. So first, let's quickly recap about the prognosis of patients with heart failure. One can see here whether you have HFrEF, HFpEF, borderline ejection fraction, regardless of any of those debates, once you develop heart failure, your prognosis goes down pretty dramatically. We are not talking about reduction in lifespan by a few months. We're talking about over a decade. And even if you're an octogenarian or a nonagenarian, you're talking about substantial reductions in life as compared to age match controls. So we really have a lethal condition in our hand. And as cliche as this might be, this is actually true that heart failure has worse prognosis than many forms of cancer. Some cancers, obviously, things like pancreatic cancer have worse prognosis, but many forms of cancer have actually comparable or better prognosis. These patients also suffer from substantial reductions in quality of life and functional capacity as well. Now, we have a little bit of embarrassment of riches in heart failure with reduced ejection fraction. Many, many trials have been done. It's really a robust field, and a lot of positive trials have come out. But that's precisely the point, that there is a lot of positive trials that have come out where there is issue of polypharmacy, complexity of therapy, and cost-related issues with this question of sequence and substitution, and all of those things come up. So how do the guidelines deal with it? This is the previous guidelines from American College of Cardiology and American Heart Association, Heart Failure Society of America. I had the pleasure of being part of this guidelines committee. The new ACC/HA heart failure guidelines are not out yet. We expect them hopefully in the next 3 to 6 months. I'm not going to go over the guidelines, but this was the guideline that came out before the SGLT2 inhibitor trials had come out, and before omecamtiv mecarbil, and before IV iron. And you can already see the complexity that, you do this and you do this, and first you do that, go up, go down. And then the European guidelines were also similar. So again, just keep the visual in mind for the European guidelines. And I want to just compare it with the new set of European guidelines that just came out 2 weeks ago. And again, not to go into the details, but there was a whole sequence suggested that you do this first and that first, and then go down the road. So what's the problem with this whole sequencing story? Well, the first problem is that, remember, sequencing of therapy is a historical construct, not a biologic construct. It was history of medicine that we started testing ACE inhibitors in the 1980s and early 90s, and then beta blockers, and then MRAs, and then ARNI, and then SGLT2 inhibitors. There's no biologic reason to prime the heart with one drug first and then the second drug later, and that you will get a better outcome this way or that way. The other problem is that we only have so much what we call spending function in heart failure. So you only have so much blood pressure, so much creatinine, so much potassium. And if you use this algorithm that you start ACE inhibitor, you bring the patient back every few weeks, you go up, then you bring the patient back, beta blocker, go up, then switch to ARNI. Sooner or later, you run out of blood pressure, you run out of something else, and then you don't optimize medication. That's, I think, less of a problem. The bigger problem is that it takes weeks and weeks and weeks and months and years, and two things happen. One is that you put the patient at high risk all the way during this, including the risk of certain cardiac death. I would say even that is less of a problem. The biggest problem is that inertia sets in. There are data, all the way contemporary data from this CHAMP registry. I was, again, fortunate to be part of this program and the senior author on this paper. And what we found is that this is 150 sites all across the United States, private practice, cardiology, internal medicine, academic sites. These were the sites that were interested enough in heart failure to participate in a heart failure registry, and we gave them an out that if a person has, forget about absolute contraindication, even relative contraindications or intolerances, just check that that's the reason the patient is not getting that therapy. And with all those caveats, less than a quarter of the patients were on triple therapy. Remember, this is pre-SGLT2 inhibitor. This is 2 years ago. So still contemporary data, but 2 years ago. So the combination of RAS inhibitors, beta blocker, and MRA was in less than a quarter of the patients, and optimal doses was in single digit. And this is contemporary data. And inertia sets in, and part of the inertia, at least, is because the way we have suggested this whole sequencing issue. So just to make a quick point about why sequencing, in my opinion, doesn't matter. First of all, baseline therapy in heart failure trials is not always 100% because nobody tolerates. So then you have a lot of opportunity to look at subgroup analysis. So beta blockers, certainly multiple trials improve outcomes on top of ACE inhibitors. So if you look at aldosterone antagonists, Rahl's trial, only 10% of the patients were on beta blockers, whereas in Emphasis trial, 90% of the trials patients were on beta blockers. Did not make a difference whether or not you were on baseline beta blocker or not. If aldosterone is going to benefit, it will benefit the patient. Valsartan, sacubitril, the same thing. 50% of the patients in Paradigm HF were on MRA, and 50% of the patients were not on MRA. And presence or absence of baseline MRA made no difference in the benefit with valsartan, sacubitril. And lastly, we come to SGLT2 inhibitor, 2 positive trials in HFrEF, EMPEROR reduced with empagliflozin and DAPA-HF with dapagliflozin. Same thing, about 70% of the patients were on MRA. Whether or not you are on MRA made no difference. In other words, if you are giving 2 medications that have totally or partially overlapping pathways, then baseline therapy matters. So for instance, if you add an angiotensin receptor blocker on top of ACE inhibitor, you don't get incremental benefit. If you add ivabradine to a person who is not maximized on beta blockers and then maximize beta blockers, you're not going to get incremental benefit. But when you have drugs that are working on completely independent pathways, the SGLT2 is different than neprilysin inhibitor, which is different than MRA, then the baseline therapy does not modulate the benefit. The second issue that comes up is the timing of the benefit. These drugs act fast. I mean, we are looking at the Kaplan-Meier curve in secondary analysis reaching statistical significance in both DAPA-HF and in EMPEROR reduced in less than 4 weeks. Pioneer, when we gave valsartan sacubitril, had a 44% reduction in hospitalization in 8 weeks. These drugs work relatively very fast, and we have seen that with every single agent that the drug starts working. So by delaying for months on end, you have a lot of potential risk that the patients get. And in terms of the symptomatic benefit, again, in EMPEROR reduced, we measured it for the first time at 4 weeks. And despite of the fact that these patients had baseline 90% ACE inhibitor or RAS inhibitor use, 90% beta blocker use, and 70% MRA use. And these were outpatients. This is not acute heart failure. Yet, in 4 weeks, you're seeing symptomatic improvement with SGLT2 inhibitor and worsening with placebo designation. So, this is the new guidelines that came out from ESC. Again, I was very fortunate to be the US representative on the European guidelines. And you see this picture to be significantly different. This guideline has given up on this whole issue of sequencing and have embraced the construct of quad therapy as foundational therapy and left it to the clinicians of how to give these therapies. 2 points I want to make. One is that it is better to give high doses of therapies that were tested in clinical trials. But remember, high doses is only an issue with ARNIs and with beta blockers. With MRAs and SGLT2 inhibitors, it's basically 1 dose. I mean, technically, yes, you can go from 25 to 50 of spironolactone, but 25 of spironolactone and 10 of SGLT2 inhibitor, EMPA or DAPA, and you're done. But yes, with beta blockers and with ARNI, you go up on the dose, you get incremental benefit. But the maximum benefit is when you go from no dose to low dose. you do get some incremental benefit when you go from low dose to high dose. So the best approach, at least the way the evidence is evolving, is to first go ahead and use low dose and block all the pathways, at least to some degrees that we know modulate risk, and then you can use your best clinical judgment to go up on the doses as needed. So this time the guidelines do not have that strict algorithm sequence, mop titrate this, maximize this a mindset. So on the right, some of our colleagues have come up with an alternate algorithm to do it. The algorithm shown here was proposed by Dr. McMurray and Dr. Packer, and they call it 4 and 4 to give 4 drugs in 4 weeks. I had the opportunity to pen this viewpoint with Dr. Fonero, and we are just basically asking that we should just dispense with any algorithm at all, because a person with hyperkalemia is different than a person with bradycardia, who's different than a person who has dizziness. And I think we should just use our best clinical judgment. At the end of the day, we are clinicians and we can use our best judgment. You know, if you have hyperkalemia, SGLT2 inhibitor may help you get on an MRA, because SGLT2 inhibitors lower the risk of hyperkalemia. If you have congestion, then SGLT2 inhibitor with beta blocker makes a lot of sense, because beta blocker initially have some negative inotropic effect. There is no biologic reason to follow any specific sequence. The best option is to give all the therapies that are needed to the patients. So why we feel strongly about this? Because if we give this quad therapy as soon as possible, one can expect rapid improvement in health status within 2 months, rapid reduction in heart failure hospitalization within 4 weeks, rapid reduction in mortality, the curve separate within 4 weeks, rapid improvement in LV ejection fraction within 3 months, rapid reduction in heart failure rehospitalizations if you are to get hospitalized, and significant tolerability of these agents have already been shown. So this is not something that you need to give for years on end before you see the benefit. In the interest of time, I won't go into sort of all of these ways by which you can facilitate the therapy, but there is a lot of ways by which we can really help our patients get onto optimal medical therapy relatively fast. What is at stake? So because these drugs have additive benefit, these are not subtractive benefits. So it's not like 1 + 1 is 1.5 or 1 + 1 is 0.5. 1 + 1 is not 4 either. These are additive benefit. 1 + 1 is equal to 2. So as we add these drugs, because these are independent pathways, the absolute risk reduction we're talking about is 25% reduction in mortality with a number needed to treat of 4. You give 4 drugs, the number needed to save 1 life over 2 years of treatment is just 4 patients. This was a paper by Dr. Vaduganathan, who will be speaking later today in this forum as well. And they said that if you were to give somebody dual therapy with ACE inhibitors and beta blockers, say 2005 era, and give quad therapy now, on average, you're extending life by 6.3 years. 6.3 years. And even in octogenarians, that benefit is extending life more than 8 years. And again, some estimates. So if you can just jump down to the last row, we're talking about potential life saves per year if we were to add on top of medical therapy also appropriate use of CRT and ICD, over 130,000 lives saved per year in the United States. So I want to end my talk by giving you sort of 2 examples of myocardial infarction and cancer. So I'm obviously very well aware of the fact that myocardial infarction is in the hospital setting and heart failure is in the outpatient setting. But we start 6 new classes of drug in 48 hours when somebody comes in with myocardial infarction. And in heart failure, we argue the nth degree of sort of academic debate about, titration and this, that, the other. And if these are the benefits we are looking at, why would it not make sense that a heart failure patient should just be hospitalized so that we can optimize the therapy? I think that would probably be in the long run really cost effective, but maybe a little bit beyond sort of what our comfort level is right now. So at least we can go ahead and optimize the therapy in a few weeks. The second is the cancer example. And this sort of really fascinates me because if you think about it, cancer patients, high risk of mortality, heart failure patients, high risk of mortality. Cancer patients get chemotherapy, which is a combination of 3 drugs. Cancer doctors sit down with the patients and say that you have a lethal disease. I have to give you the combination of these therapies. That is the best chance of making you live longer. That live longer may be a year. And you will have a lot of side effects, but let's first save your life, and then we will deal with the side effects as they come. Now come to cardiology and heart failure. Any little thing, potassium of 5.2, some dizziness, we give up on the medication, we don't up-titrate the medication. Cancer doctors don't say that I'm going to give you 1 drug and see what happens to the burden of cancer, and if the cancer burden progresses, then I'm going to give you a 2nd drug. They give the best evidence right up front. In heart failure, we give 1 drug, and then we say, why don't we just wait for you to see if you get stabilized and if you get worse. There is no cardiovascular disease where we have this mindset, right? I mean, if you have a person with systolic blood pressure of 160 or LDL of, 160, hemoglobin A1C of 10.5, nobody will not treat this patient by saying, let's wait for you to develop symptoms because you're asymptomatic. And yet we say, well, NYHA2, I will wait for things to get worse before I would give you optimal therapy, which does not make sense. So we published this in American Journal of Medicine, and I got a whole Twitter storm against me and got a lot of criticism for writing this viewpoint. And we said, polypharmacy in heart failure with reduced ejection fraction, problem, not progress, not problem. And what we were trying to say is that polypharmacy is a real blessing. The problem is polymorbidity. Patients have too many diseases. So yes, it will be great if we all took care of our health and did not have comorbidities. But when you sort of ratchet up the whole dialogue about polypharmacy being a problem rather than being a solution, that's where subconsciously then you have all of these other dynamics that sets in. So we got a lot of comments on the Twitter saying, oh, well, whatever happened to, Hippocrates' oath, and, first do no harm, and how can you say this? And I just don't understand this whole notion of first do no harm. First of all, the only way to do no harm is to do nothing, which ironically will do the most harm, right? I mean, there is no medication that does not have side effects. And don't we actually mean first do no net deliberate harm? And we really need to get beyond this first do no harm notion, which leads to a lot of inertia in medicine. And we also need to realize that not giving beneficial therapy is actually doing harm, and it's doing much greater harm to the patients. So I end my presentation again with showing this curve that if cancer has the same mortality as many forms of heart failure, why is there so much apathy in treatment of patients with heart failure? And I would again conclude it's not an issue of substitution or sequencing. One other last quick point that I would make is that this issue of subconsciously getting cost involved in how we treat the patient. I practice in the state of Mississippi, so I'm not oblivious to these issues of cost. I mean, cost is really, really an important issue. But remember, we need to get the science first. It's only a matter of time, 2 years, 3 years, ARNI and SGLT2 inhibitor, all of these things will be generic. Let's at least get the science right. Let's talk to our patients and have shared decision making. Talk to them and let them be the decision maker, whether they want to use the copay or not do the copay. But when you're talking about less than 25% optimal medical therapy use, triple therapy, less than 10% quadruple therapy, yes, there's a lot of self-pay patient, but we don't have 90% patients without insurance. I think there's a lot of things that we can do in healthcare to improve our patients. Thank you very much. Sorry if I was standing on my soapbox a little bit too much, but that's how I feel. Thank you.